So hello everyone. Today we will have our meeting. So I'm going to share with you the agenda for today. So basically we will talk about delirium, and it's a very important topic for you guys, and especially those who will treat all the patients, especially in the setting of the hospital, like at the hospital or even other places. So patients with dementia, they may have some delirium at one point. After surgery, patients may go um, like they display some symptoms of delirium as well. So I'm going to share with you the screen. So the first topic will go over some basics of the delirium, how to diagnose and manage that. Second one, we will talk about how to write a letter to the editor, and then maybe we will touch base on the abstract, how to submit one that can be accepted easily. This is a video from the AGS, the American Geriatric Society Conference. They tell you how they look at abstracts submitted to them, how to review them, so how to meet their criteria, basically a cheat sheet for you guys. Perhaps at the end we can go over some of the map, how to get an interactive map so that when you present or you talk about incidence prevalence in the US, for example, you can use some of these tools. So we're going to start with delirium. Delirium basically is change in condition. What it is, usually the patient will be at their baseline and something happens, and then there is a change. So what's the incidence of this incidence, or how frequent can we see this? Usually, it's, as I mentioned, it's seen in the setting at the hospital. Patient gets admitted with change in mental status, or after surgery, or in nursing homes. Patient may have UTI infection. So the presentation will be more or less the same. And we will go over this. Then we will touch on how to recognize, diagnose, and the pathology or pathophysiology, and then how to treat and prevent that from happening. So there are different ways of naming the condition. Delirium is one of them. Other diagnosis name for the same condition is acute confusional state, acute mental state changes, or other mental state, organic brain syndrome. Sometimes they call it reversible dementia. It's a differential diagnosis when you see patients who might look like they have dementia. And the last one, or more commonly known as metabolic encephalopathy, or sometimes they call it toxic encephalopathy. So when we look at it, there are difference in the incidence or how frequent. But as we get older, the older patient may present with this more. So 1 in 3 or set of the older patient presenting to the emergency room, they may have component of delirium. And as I said, at the hospital after surgery, there are a lot of older patients who present with delirium as well. And 1/3 of the inpatient age 70 or more in a general medical unit, they may have delirium. I remember when I was in my first year in internal medicine resident, one of my patients was delirious, and my senior was treating that patient, and he was guiding me through how to assess the patient and how to manage the patient. So we'll go over the details in a minute. So it's important because it has risk related to it. It has 10-fold risk of death in the hospital when we diagnose delirium. 3 to 4 or 5-fold increase of nosocomial complications. So the stay might be prolonged at the hospital. Post-acute nursing home placement is also a possibility for patients with delirium. As we get older, our functional level may decline, but if you get delirium on top of that, then there is an additive effect. So poor functional recovery can be as a result of that as well. The death rate also might increase. So in general, persistent or delirium can lead to poor long-term outcome. This is why we need to learn about delirium. How to recognize it? So mostly recognized by people who know the patient. At the hospital, nursing staff who are on the floor for a long period, they recognize the patient is different. So they can approach you and tell you, hey, this patient looks different today, or something happening to this patient. As doctors, usually we round on patients, you see them for a few minutes, maybe less than an hour or so, and you go to the next patient and so forth. If you come back later, you may see the patient again, but your time with the patient is limited. It's not like the staff, especially the nursing staff or the SINA, the nurse aid staff. So most of the cases are documented or recognized by the staff. So this is why we work as a team, especially in nursing homes or at the hospital. So the history might be obtained not from the patient only, but from the staff as well. If the patient coming from the emergency room, from home to the emergency room, then we rely on the people coming with the patient, spouse, children, or something like that. So we'll go over this. Then this is the diagnosis from the DMS. As for it has their own criteria. So the method that we can assess with delirium is called the CAM method, or confusion assessment method. This is a tool that has been developed many years ago by a nurse, and that nurse was very involved with patients. So she paid attention and came up with this assessment tool. It's very useful and it's very sensitive and specific to recognize this condition. So the criteria, you can go over this, but basically there is disturbance of consciousness with reduced ability to focus, sustain, or shift attention. So basically when you talk to a patient, they can follow your conversation. If they lost that following or focusing, then you may think, hey, something going on. The other thing is change in condition. So the patient may have memory deficit that's out of normal for the patient, or disoriented, or disturbance in languages. So if they were fluent and all of a sudden they can't find the word or they cannot express themselves, that might be another component of the criteria. Its incident or onset is usually acute onset, usually over days or hours, and it's fluctuates, so it's up and down. At some point, the patient may be focusing with you, and at another moment, they may be dazed or maybe confused. So it depends on when you see the patient. You may see them at one point, but the staff will tell you, hey, this patient is confused. So you come after 1 or 2 hours later, you see the patient, they may look like they are back to their baseline. So it's up and down. So you want to take a very good history. Exam is very important, and with both of them, physical exam and history, you can pinpoint what's going on. Labs and other imaging might help you and confirm the diagnosis if there is an underlying condition that you can figure it out. In general, in geriatric, we usually blame medication. So it's better to look at the medications and see if there is new medication added or drug-drug interaction. Sometimes that might cause delirium. So sometimes, as I mentioned, it's called confusional state. So there's some confusion component. So you need 1 and 2 out of these criteria, and then 1 of these. So you need to have an acute change in mental status and fluctuation course. Inattention is important. So these are the 2 important components, and any one of these 2, disorganized thinking or altered mental status or altered level of consciousness. These are the criteria basically for diagnosing delirium. So the spectrum of delirium, we have 2 or maybe 3 component or classification types of delirium. So the hyperactive one or agitated delirium, that's 25% or less of the cases. So they will be agitated, angry, or some component of aggression maybe. The other component on the other side is hypoactive delirium, which is 50% or less. And this can be 50% of cases. The other classification is mixed, so patient may have the 2 classes together. So what's happening actually, we don't know exactly what is going on, but there are some theories, some mechanism that can be explaining the condition. So acetylcholine is an important neurotransmitter for the cognitive process. If there is imbalance of this acetylcholine, that can be contributing to the change in the consciousness of the medication of the patient. So it's caused by anticholinergic drug overdose or using it with other medication, and this reversed by physiostigmine. So any medication that has anticholinergic activity, you think about maybe it's contributing to the condition. There are other mechanisms that can explain what's going on. I'm not going to go over the details, but you can review these slides later. It's available online on the app. But I'm going to go over here the predisposing factor, the risk, who are at risk. So as we mentioned, older patients, so advanced age, patient with dementia or cognitive problem to start with, functional impairment in ADLs, the activity of daily living. If they have multiple medical conditions, comorbidity is a risk. Using of substance like alcohol, for example, male tend to have delirium more than female. And if they have sensory or hearing impairment. So there are some factors that also contribute to the delirium. Let me answer this just a second. So sorry about that. So we will go over the precipitating factors. So if the patient has some infection, for example, they may come up with delirium. If we change some of the medication, can cause delirium. Restrain at the hospital, for example, they can cause that. Any change in the homeostasis like anemia, electrolyte imbalance, dehydration, fecal infection, all this can be contributing. Urinary retention, involving catheter, for example. Drug withdrawal, so patient was taking alcohol every day, come to the hospital, they may stay for a couple of days, they don't drink alcohol, then they may start having episode of delirium. So you take good history, you observe the patient, and you can get the diagnosis right on the spot. After surgery, a lot of patients, older patients, may have delirium, as we mentioned. So how to prevent this from happening? Sometimes what happens at some of the hospital is, as soon as a patient comes to the emergency room, all the patients or patients are planned to go through for surgery, they assess them, they see what are the risks for delirium, and they will try to minimize the risk after surgery, for example. So again, I want you to take a focus history, good history, and this will include medication, over-the-counter medication, alcohol use, substance abuse, and so forth, and good physical examination. Oxygen is very important. My patient, she had problem with oxygenation, so she kept taking the nasocannula tube out of her nose during the night. So during the day, she was confused, her oxygen level was low. So you need to also pay attention to the need of the body of that patient. As far as lab, you can order the basics, CBC, CNP, and so forth. And then you can get more imaging results. For example, you can get I like chest X-ray to rule out pneumonia. You can check urine to check out UTI, rule out UTI or infection. You can do CT scan to rule out any bleeding, for example. When a patient had a fall and they didn't report that with your CT scan, you may find some bleeding there. EEG can be used also in some patients. So it's a teamwork when we come to the management. So the principle is you take care of the patient along with staff, like the nurse staff, the nurse aide, the family, and so forth. Usually it's multifactorial. So we tend to address one, but think about it, you address more than one. So patient may have a little bit of anemia, a little bit of hyponatremia, and then they may have dehydration, and also they may have UTI. So you treat UTI with antibiotics, hydration, maybe you can give IV fluid or encourage oral fluid along with managing the hyponatremia. You can add some iron. If the hemoglobin is low, you can give blood transfusion. So it might be more than one component for treating the underlying cause or causes. Again, the main point is you identify and treat the reversible causes of the problem. So if it's medication, you try to stop the medication or change the medication. Pain is a component that can cause delirium. Pain medication also can cause delirium. So you want to figure out what is the problem. You try to change that. If the patient is alcoholic, then you need to give the medication that suppress them from withdrawal. Ativan, for example, there is a pathway. Each hospital they have their own, but there is a pathway for alcohol management so that you can prevent withdrawal symptoms, including delirium. This is a list of other medications that may contribute. So you want to use it appropriately. You don't want to put the patient on physical restraint or pharmacological restraints. So you want to avoid any polycatheters, any IV fluid access, because they cannot pull this out and they may injure themselves. If you really want to use something, maybe you can use Haldol. It's antipsychotic, and this when the patient is at risk for themselves or for others. This is a doses that can be used for behavior problems if the patient is aggressive. Rehabilitation is another way of managing the patient. So you want to use some clocks, some calendar, radio or TV to just orient the patient to the time, day, and so forth. You want them to have a good sleep at night, wake during the day, able to mobilize or ambulate the patient. If they have eyeglasses, you can put that on, hearing aids, and so forth. So educate the family and the staff about how to reorient the patient and minimize the risk. So the prevention is the best option. If you recognize it earlier, that's well and good, but it's better to prevent it from happening. As I mentioned, some of the hospital, they have teams that are working to assess patients who will be admitted from the beginning regarding the diagnosis of delirium so that they can manage it right away, or they can prevent it from happening. So this is the summary. Delirium is common, can be diagnosed with high sensitivity and specificity using the CAM method. You need a very good history exam and focus lab. So we'll use tools and that can help to identify the underlying cause. Medication is very important. I tell my students, every question in geriatric, the first answer should be medication. So any problem happened to the older patient is because of medication, unless otherwise proven something different. So you start with medication, medication, medication. Then you think about infection. Then you think about what other component that inside the patient, like electrolyte imbalance, dehydration, oxygen, anemia, and so forth. Then you look at accessories, eyeglasses, hearing aid. Then you look at the environment and so forth. So careful medication review is very important. The management start with primary cause and avoiding these problems. Any questions? So I'd like to introduce Dr. Ahmed Abdelrahman. He is from Mayo Clinic. He's a nephrologist, and he is one of the founder of this program. Welcome, Dr. Ahmed.
السلام عليكم نادر. السلام عليكم كل الحضور. لعلكم بألف خير وعافية. I'm happy to be with you today, and really I'm honored, and I'm enjoying the session, Nader.
Thank you.
Thank you.
Dr. Ahmed, you're welcome. So he is at Mayo Clinic. He's a nephrologist. He did his fellowship in Florida in nephrology. He finished internal medicine before that. So, okay. Any questions from the fellows? Anyone who had encounter with patients with delirium at the hospital here in the US or other places? Can you share your experience?
Hello, Nader. Can I add?
Dr. Ahmed, please go ahead. Yes.
Hello, everybody. I am Ahmed Abdelrahman, and trained nephrologist, and also I'm clinical pharmacologist and consultant in internal medicine at Mayo Clinic. And thank you, Nadir, for the comprehensive talk. And this is very important. So talking about the delirium, and I want to brought delirium with surgery, especially with hip fracture in elderly, and the use of pain medication. So one of the things we should anticipate preoperatively is the development of delirium in our patients who are undergoing surgery. This is important. And because the incidence of delirium is high because of surgery, because of medications. And thank you, Nadir, for reminding us of medications as a cause of delirium, which is one of the commonest. The other thing is that, especially pain medications, if we could shy away from injectable to something like patches, it will be better, especially for patients more than 65 years old. The other thing is that also we should pay a close attention to electrolyte imbalance, especially sodium. In addition to the many causes you know about hyponatremia, also we should know that pain also will cause hyponatremia. So sometimes treating pain will address the hyponatremia issue as well. Thank you. Thank you, Nadir. Nadir, you hear me? Hello,
Yes,
Nadir?
thank you so much, Abdelrahman. Yes, thank you so much.
Yes, I hope my voice is heard back that.
It's clear. It's clear.
Yeah, okay.
Yeah, thank you so much. Appreciate that.
Yeah.
Anyone else would like to share their experience or?
The biggest football arena. Final match is still about to begin. It's the match that's going to decide the championship. Both teams already on the pitch.
So if none, then we can move on to the next topic. So in writing papers, for example, sometimes you can review some of the papers, look at them, read them, and sometimes it's beneficial to know what's going on. Keep yourself up to date. But sometimes when you go along, let's say you become a consultant, you need to know you have the opportunity of either correcting some of the articles that show up in some of the journal, and sometimes you may add your experience as well. So let's say there is an article came out in geriatric and in telemedicine. So this is my interest. I'm a geriatrician and I'm interested in telemedicine. And during COVID, we used it and we come across different use of telemedicine. So in the past, they approved certain opportunities for physicians to use telemedicine, but there are some limitations. When COVID hit, these limitations were lifted. So many physicians were able to provide care using telemedicine. So recently there are some articles in this area. So one of them talked about telemedicine. So I can look at that article and then I can comment on that article. When I do that, this is called letter to the editor. So what basically you do, you look at the article and then you can compare what's the findings, how is the method used, and what's the conclusion. If you agree with the conclusion and you want to add more to that conclusion, you can express your experience and then say that in our experience, we found this, and you can add support to that article. Or if you do agree with that findings, you can do the same. You can express your experience, share it as in our experience, we found it to be so and so in comparison to what's written in that article. And then you can explain what could be the difference. And the sample might be different. The location of that sample of patients might be different. Comorbid conditions in this group of patients may be different than your setting. So you can comment on what could be the difference in the conclusion or the findings between what you observe in your experience and what's happening or what's published in that article. So this is how you can do that. And it could be a brief one and it could be longer, but you can add some references to your letter to the editor. I'm going to share with you one letter that I added recently to the family medicine So this is an article came up about the, artificial intelligence. So they talk about why ChatGPT should not be used to write academic papers, for example. So I think I disagree with it should not be used totally, but I think we can use it partially, in a sense that we can use it to help, especially patient authors who are coming from other countries or English is not their first language, or to improve their layout or to improve their presentation, as this could be a little bit tricky because it's an art when you write. So the more you write, the better you get at it. But if you have some tool to help you, I think it's gonna be very important. So I wrote an e-letter, nowadays they call it. So letter to the editor. In that letter, I explained to them that, hey, this is a useful tool, but we need to use it with some careful limitation. So nowadays, most of medical schools, they are encouraging their students to use ChatGPT, but the limitation is not to use it when you write the whole paper. You don't copy paste out of the ChatGPT findings, because there are tools to identify the findings of these papers or the parts written by the artificial intelligence. So this is how you can write a letter to the editor. It could be very simple if you know the field or the area. And then when you look at the article, if you find the areas that you want to share with your experience, you can add that. Or if there are areas that you want to debate or refute or address or clarify, then you can share your experience, because sometimes it might be different aspects, so different perspectives, different views. So this is how we look at the letter of letters to the editor. Thank you. Any questions? Ahmed, you can jump in and share with us your experience in this area. Thank you.
Thank you. Really, Nadir, you have said it all. And about the letters to editors. But I would like to bring one thing in this discussion. So I congratulate Nadir and all the fellows about the very successful fellowship program. Really, very nice ideas are being discussed, and also papers are being published, and that is a great thing. And of course, a lot is to come ahead. One of the things I would like to address is the issue of artificial intelligence. And really, it is a helping tool in all disciplines in medicine and on other branches of science. So I encourage everyone to study and to probe deeper into this field of artificial intelligence, because it is one of the tools in the future, and especially likely in the coming few years, it will be a very common tool. So in this fellowship, I encourage that if we can publish in these fields as well. And before we publish, of course, we need to review some topics in the fields of artificial intelligence in our respective field, and also other in all fields of medicine. One of the other thing is that I would like to discuss is citing. if Nadir, if our time allows.
Yes, go ahead.
Yes. So, and I will take these things as just, we will start simple and then go further. And I know some of you have written papers and also abstracts. But one of the things that is sometimes even maybe need some revision, even in those who are skilled in writing papers, which is citing. And when you cite, of course, you are going to read a lot of medical literature, but in citation, also I need to remind my colleagues and everybody is the review a lot and more than is needed is not required. For example, the average author will write about 5 papers in a year. And if it is comprehensive paper, it might be each one is 130 references or citations. But if you are writing like a paper that needs or is specific to a certain discipline, you can cite about 40 reference, only 40. Okay. So, and each idea, you can cite 1 or 2 reference, and it is better to cite the original one. And in citation, the more recent is better than the old references. For example, you could find a reference that has been written about 20 years ago. So the most recent are of significance. So limiting citation is very important. And also talking about citation, I want you to be aware of the fact that the citation itself should be read, and you know all the details about the reference you are citing. And in JAMA and the surgical and they review randomly some of the papers where the authors haven't like read in details the referenced papers. So that is something we should actually know about. Also, nowadays the errors in citation are less, and because of citation managers. And every author should be like have a good command about 1 or 2 of the citation managers. And what I mean, like there is something called EndNotes. This is one of the best, and where you can organize your library. For example, if you are interested in hypertension, for example, you will have EndNotes library where you organize your reference. And also at the same time, you can even add the PDF files so whenever you want to revise hypertension, for example, you will have your library already established. Not only that, if you are publishing like something, hypertension is a big topic, for example, secondary hypertension or pheochromocytoma, you will have your papers. For example, you could have 10, 20 papers, and everything comes new, you will add to the library. So by doing that, you will really manage your time well. And also you will write your paper in not a lot of, you are not wasting a lot of time. Not only that, you can collaborate and you will be like well-rounded in your specific area. So every one of you about to write an abstract paper, please put in mind that review and citing is of significance, of importance in the fellowship and in your career going ahead. So be mindful of that. To try to familiarize yourself with the citing managers, and some of them are free, some of them you can purchase, like EndNotes, or it could be part of the institution you are working with. Have your own library and you carry it with you. Some professors have their citing managers for many years. So sometimes you see that people who present in conferences elsewhere, they cite and they have papers back maybe 30 years ago or more, even more than that, because they have their own library and it is easy for them to be done that way. So be mindful of that. The accuracy of citation, as I mentioned earlier, is nowadays is very good because of this citation, because it is just a click away and it will bring you the author, the journal, the year, and you can put it in different format according to the paper you are about to publish in. Yeah, very good. And this is the citation styles, which is you just pick it from the citation manager. And I think this is what I have to say about this important tool in review and also citation. And even in future, if you become like editor-in-chief or reviewer, you need these kind of tools and you need to be to know them well. Knowing one is important. It doesn't mean that you have to know every single citation manager. Thank you.
Thank you so much, Dr. Ahmed, for this helpful comments. Any other comments or questions, or you want to share your experience? Please go ahead. So we're gonna jump to the next agenda item, and that will be how to write the research abstract that will be accepted for SBS. So if you go to the app for the calendar of the agenda for today, you click on this video, and I'm not gonna turn it on play it because it's not gonna have the voice for you guys, but I can share it with you on the chat, so you can review that later. We just add it to the so it's the link is on the chat, but basically they want you to work on something related to their themes. So usually they will say in 2024, we're gonna focus on these areas, telemedicine, falls, infection control, something like that. In all the adults, for example, this is the American Geriatric Society. So as long as you are within these themes, your abstract will be 90% accepted, unless it's totally rubbish. But if it has material in it, if you write your background as far as why this abstract is important, why the topic is supposed to be discussed. So you need at least one or two references. Dr. Ahmed mentioned that. You need to give a background about the topic. You need to raise the importance, the impact of that topic. And then the next step will be your method. You need to use a method that's very strong. If you have the method written, then the results and the conclusion will be as a secondary point. So the more important parts is introduction and the method for the abstract to be accepted. Sometimes they can accept the abstract only on these two factors, with the expectation that you will finish analyzing your data and then presenting the data and the conclusion in a later date. Let's say they have a deadline, you submit your abstract on January, for example, 12th. So by January 12th, if you didn't finish the abstract, you still can submit it, even if you didn't start the analysis, if you collect the data. So you submit and you comment, and with that submission that you are working on the data analysis at this point. So they can accept the abstract with the title, the authors, the introduction, and the method. Then they will tell you in 4 weeks, we want to receive the data and the conclusion. So by that time, you need to finish your abstract. So basically, you can work on analyzing the data, finalizing your findings, and finishing the conclusion, and submit it, let's say, in that 4 weeks period. You submit it, then they will give you the approval. Your abstract will be accepted 100%. If you are working from the get-go, from start, you finish your abstract and everything is all set, by the time of the deadline, you submit the whole abstract. Most of the time they will accept. We had very successful rate when we applied or submitted our abstracts to the AGS in the past from the first batch in this group, and also with other conferences. So they want you to work on the research. They want to encourage you. So as long as you have a research idea, research question, and you work on getting that into a format, let's say an abstract format, you need to work on getting the background, and you need to find a method to get the information, analyze the information. If you have these two components, it's easier for the abstract reviewer to say, oh, that seems to be a good abstract. Then they go on to review the data and the findings. If you have it, if you don't, then they can wait and then review it in a later date. And then they accept it. So basically, this is what the video will show you. Maybe it has some more details. So if you have time, I encourage you to look at that video. Next, we can go to the interactive map. We can use this map for there are different ways of using a map. Google has one way of doing it. So I'm going to just share with you what we used here. So again, if you go to the app that we share with you, if you go all the way down, you will have this map. It's a Google-based map, so you can edit that. So what I did is I put a list of the fellows who matched. So this is the list of the fellows from the first batch, second and third batch, who matched and what program they matched to, what's the city, what's the state, and their names and the type of residency or fellowship, all this. And then I converted that to an Excel sheet. So I just copied paste that into an Excel sheet. And I went to Google Map, and there is a way to have your own map. So what I did, I created that map and I added the list from the Google Sheet. Basically, you upload the data. So the website is called mymaps.google.com. So this is a website, mymap.google.com. When you log in, you can create a new map. This is a map that I showed you. I can edit that and I can update the information. There are 62 items or fellows in this map. So I can edit this information and I can update it if there is one or more new fellows who accepted to programs. They can let me know and then we can add them. For example, Sarah was accepted in Texas. In Florida, we have Andrew. He was accepted in fellowship somewhere there. So this is how you create that. You can share it, you can preview and then edit. You can add more than one layer to that program. I used it also in the past for a topic that I was presenting. So I was trying to explain to the audience that, for example, I have worked with patients in Boston, Mass General Hospital, and then in Pennsylvania and so on. So I have some component there, and now I'm in Lansing. So I tell them this is how I started my journey. Or if I have a patient, let's say in a nursing home, he is in need for help, but doesn't want to stay in nursing home, and his family lives in, let's say, in Boston. So we will communicate with Boston where his family is. Then we will see how they can help if they can. If they cannot, we can transfer the patient to an assisted living or a skilled nursing facility near his family or her family somewhere there. So this is how you can demonstrate your topic using the interactive map while you are either talking, or you can get a screenshot and put it in your abstract or in your paper or any format that you want to present. So this is one way. There are different ways of using the interactive maps, especially like when COVID hit, we have patients identified in Washington State. So this is a red area, for example, and then more patients were discovered in New York City or New York State. Then this is the two hub areas, then Texas. And so you can use this map to track the spread of the disease, for example. And you can use it for Lyme disease or malaria or some other ways of tracking incident of disease or events and so on. So there are different ways of using the tool. I just want to share with you that. Thank you. Ahmed, can you help or can you share if you have any comments? Thank you. Or any one of you, if you have any comments or questions, please go ahead.
Hello, you hear me, right? Sorry, I was in mute, but right now you hear me, right? Hello?
Yes, yes, go ahead, Dr. Rahman.
Thank you, Nader. You covered it all. I just would like to comment about the abstract, which is very important, and it is a mini representation of the manuscript. So it has to be well written, and it depends. It could be structured or unstructured abstract. But we have to make it very clear and in a very like concise way, and it should address why is there a need to do this study, simply. And how was the study carried out? The third thing is what key aspects or limitation of the study would our readers need to know about or need to be aware of? The other thing is that what exactly was done? Like it could be a clinical study, it could be a clinical trial. And by the way, abstract, I think, has been like people invented, I have to say, in 1987, and they are specifically used with clinical trials. So the fifth thing we need to know is what were the findings. So what brought this is the study could be a clinical trial, it could be basic study, and at the end it will lead to generation of knowledge. So we should make a good presentation of how exactly does the new knowledge that we have generated is to serve our patients or our clinical community. So if we make this clear, then we have a good abstract, and it should tell us what is in the manuscript. Having said that, and we will go back to our review process and citing. If you are citing a paper, please read the whole paper, not just the abstract, because it is found that some authors are just fine with the abstract, because sometimes we need to elaborate more, especially when we are dealing with complex ideas and when we are kind of generating basic or even clinical or even translational paper. So we need to read the whole paper, but the abstract in itself will give us a very good idea. Thank you, Nadir.
Thank you, Dr. Ahmed. So I'm going to just use some example of the fellows who did present in the past, ABS, for example. So if you go to the website of our program, it has TGRF publications.glide.page. You don't have to do all this, the rest. So this is a web page, basically. If you go there, it has a list of our mobile applications and so forth. But if you go to the abstract, you can find some of these abstracts that are listed that has been accepted in the past. So these were accepted in the AAIC, that's the Alzheimer's Association conference. We have some in the cardiology conference that has been accepted. This is the ones that we discussed or we presented AGS. So one of them about cardiovascular risk factor in COVID in artificial intelligence and a better approach to pandemic. That was in 2021, so 2 years ago. So the idea of that research is we look at patients who were admitted to Sparrow Hospital here in Lansing and look at the risk factor for them to get into the hospital, why they are at risk. And our approach is to see if we can identify patients with this risk. Maybe we can use artificial intelligence to predict who will be at risk for COVID and prevent this from happening, or at least educate and prevent, something like that. So other topics including case presentation with use of steroids in patients with dementia. That is, the patient was displaying some neuropsychiatric symptoms, some aggression, some agitation, some depression. So some use of this steroid injection may be of help in nursing home setting. So this was a case presentation, and we have more. So if you go and look at this, it will show you the video for the presentation of that abstract and well as the component. So as Dr. Ahmed mentioned, So you start with the research question. The title will grab the attention of the reader, but you want to focus on why you want to handle this topic. So in 2019, 2020, COVID was a big health topic for all healthcare workers. So it's very important to know what's going on. So at the hospital, death rate was high. So we wanted to identify or stratify or find the risk of other illnesses that associated with patients who, let's say, go to the hospital. So we want to identify pre-existing cardiovascular disease conditions in this group of patients. And then we had another poster about other conditions, not necessarily cardiovascular. So in this topic, our aim was to develop a risk factor stratification tool using artificial intelligence method to predict mortality, ICU admission, and length of stay in patients with COVID during this pandemic. So this is the goal. As you just mentioned, Dr. Ahmed, you need to identify why you want to do this study, what the benefit, what the question, what the outcome of this study would be. So sometimes we are successful at reaching that aim, or sometimes we are not. So you just try and see how it goes. So you display or you share your experience on your method. So our method at that time is to review the chart from the hospital. To do that, any work with patients, you need an IRB approval. So we went ahead with a proposal and we wrote that and asked for IRB approval from both MSU, Michigan State University, and Sparrow Hospital, and we got that approved because our data collection did not include identification information like the patient name or date of birth and so forth. So we collected aggregation of patients who had, let's say, heart disease and COVID, something like that. So the risk is minimal for these patients. If someone look at our data, they cannot identify the patients, something like that. So in the method also, you should identify your sample or your participant. In this case, our patient selection will be older patients. So the cutoff for us was 60 and older. I was listening to a lecture this morning, and the presenter was saying usually the cutoff age for older patient or older adults nowadays is 50. So if you are 50 or old, then you are older. If you are less than 50, you are younger adult. So this is cutoff. But in this paper or this abstract, we used 60. In the literature, most of the time, you will find 65 is the cutoff for older patients. So, and there is a difference, slight, as far as giving the age as a criteria. So we looked at all these patients. You have to identify what period. So from March 2020 to October 2020, we included all these patients who have, we identified the risk factors as hypertension, any condition, chronic ischemic heart disease, heart failure, arrhythmias. These are the criteria for inclusion. So we found about 426 patients with COVID. So this is the analysis of that data. So this is how you come up with the abstract. You have the idea, you identify your method, what the variables, what the data you want to collect. If you are looking at the charts, if it's electronic, it's going to be easier. In the past, it used to be hand and the paper chart, so it's going to be time consuming. But nowadays, most of the hospital, if not all, they are using electronic medical records, so it's easier to gather information faster. in our case, we used what we call a query. So Spare Hospital, they have their own database team where they keep track of all the data. So we asked them to find every patient who has the diagnosis. We give them the ICD-10, which is COVID infection. The age, we want them to identify patients who are 60 or more. And then we want them to figure out which patient has hypertension, coronary artery disease, or congestive heart failure and arrhythmias. So they can do that with one query. They can get the information instantly in table format for us. And that's what happened. So for us, it wasn't as difficult. The IRB approval was not as difficult. It was fast. Collecting the data was fast. Then you analyze your data, and then you come to the conclusion part where you will say what you think this data shows. This is one abstract, and you can go to other abstract as well. So we used, I think we participated in other conferences. For example, this one was presented in the NAPGREC, the North American Primary Care Research Group, that was recently presented in California. So we don't have the video, but if Naud is there, he can also explain the topic. So the topic title will be Catching about COVID, and then we will have the introduction as the way of demonstrating the importance of the topic, why you want to study, and what's missing in the literature, or what's your aim, what's your goal, and you come back to the method. So this is a systematic review. So we use PRISMA guidelines as far as this. And then we collect the data and analyze the data, and this is a presentation. So this is how you write your abstract. And if you have the time to analyze the data, combine all the findings and write the conclusion, that would be great. If you cannot finish by the deadline, you can submit partially completed abstract, and then you can finish, and then in a later date you can submit your abstract. So if Naud is here, you can participate and share your experience, or if Abdelrahman wants to add your comment, please go ahead.
Hi everyone, can you hear me?
Yes, go ahead, Abdelrahman.
Yeah, as Dr. Nadi was explaining the concept of presenting a poster, just to give a quick glimpse of what your systematic review looks like. So a poster presentation is a bit different from systematic review. Systematic review is a bit detailed as compared to poster presentation. Poster presentation is just like a quick summary of what does your systematic review look like. So this group was led by Dr. Asma, and the title was the Physical, Mental, and Social Difficulties of Older Patients greater than 65 years of old during the COVID-19 pandemic. So in the introduction, we just included what does the COVID-19 look like during the pandemic, especially on the older population, and how does it affect the older population. And in the meta section, we just included what kind of methods we included for excluding and including different literature done prior to 2022. And in the discussion, we focused primarily on the older patients which were affected by the COVID, and how does this COVID affect them mentally, physically, and socially. And in the discussion, as well as in the conclusion, we try to promote at least or formulate a plan for supposedly if a new pandemic of any form comes, how does a disabled patient above the age of 65 would be affected by the upcoming or becoming a new form of a pandemic. And in terms of the presentation, Poster presentation is a bit precise, simple, and to the point as compared to systematic review and meta-analysis, because this is just like a summary. It's a quick glimpse of what you have found and what you want to promote in your paper. And from the audience, also, the question is a bit different as compared to a reviewer who is going to review a systematic review. A reviewer who's going to review your systematic review is going to be more extensive and more detailed when they give you a comment and a correction. In a poster, it's just more of like a 4 or maximum 5-minute summary of what you have found in your extensive systematic review. And regarding presentation, there are 2 ways of doing this. One is just if your systematic review is partially accepted to any form of journal, you can present it as a poster as a form of conferences. Or if your systematic review have already been presented and publish it in any form of journal, you can present it as a new form of poster to a new conference. All in all, the concept of presenting a conference or poster is just give a quick glimpse of what you have found. It's not about details. It's not about discussion of what you have found in terms of percentile. And it's also a good way of connecting with people who have the same interest as you, probably new residents or residency applicants, or probably new medical graduates. All in all, it's a good way of like exposing yourself to the research community. Thank you. Dr. Nadia, you can take over.
Thank you so much for sharing, Dr. Noor. Anyone from the group or from the fellows, the seniors, wants to share their experience or their any comments regarding the abstract submission? Or
Hello.
hello, go ahead, Dr. Faida, go ahead.
Thank you, Dr. Nadir. So the only thing that I want to add also is that each conference or each meeting, they have their own template and they have their own rule. So it's also important to bear in mind that as everyone has been mentioning, that it's our responsibility or it's the presenter's responsibility to reflect the points that you want the others to know. So you need to bear in mind that, like, for example, there is certain societies that they put like 300 words or 250 words limit to the whole abstract. And there are others even who put limits to each section of the abstract. So it's the sole responsibility of the person who writes the abstract to reflect the important aspects of the research that you think that should be presented within that abstract. So yeah.
Thank you so much, Dr. Faida. Thanks, Dr. Noor, for sharing. Yeah, it's important to look at the requirement when you submit your abstract, as well as when you submit your papers, manuscript. Some of the journal also, they have their own templates or their own requirements. So it's better to follow their requirements so that you can have a high chance of acceptance. Thank you for sharing. Anyone else?
Yeah, I think, I don't know if I remember during probably before 6 or 8 months, I think Dr. Nadir was discussing about the session of how to present a paper, when to present. So as Dr. Rufaida was explaining, different journals and different conferences have a specific template, a specific word count, a specific texture or type of text you have to complete and you have to submit. There's a good website by the name of Jane, I guess. Last time I checked, that's a good website. So when you go to that website, Jane, they will give you the impact factor, whether it's indexed into the big journal, second. And third, also, when you click that one, they will give you Yes, this one. So you can kind of like type the abstract title or text here, and they will give you different journal specification in terms of the impact factor, word count, the indexed parameter of that specific journal. So accordingly, you have to take a risk of like, if you are impacting or if you are, let's say, aiming for a big journal, which means your margin of error has to be small and the chances of you being accepted as a journal is high. If you are just more concerned about having one auto publication in your CV, then you should aim for some sort of a journal where the impact factor is middle and index correction error is a bit low. So let's say, I think Dr. Nadi is trying to find a journal for specific abstract. So they will give you a different form of like journals, different name, impact factor. There you go. So the one on the middle will show the article influence or impact factor. Whether they are PMC indexed or not will be highlighted on blue. And the quality of the journal or the acceptance rate will also be highlighted in different form of factors. So depending on this, you will take a risk or maybe kind of like a calculated assumption of what are the chances of your abstract being accepted or not. So if you feel that the quality of the paper that you are presenting is a bit low, it's better to aim for an article with influence factor of about 1 up to 1.2 or maybe up to 0.8. If you feel that the paper that you are presenting is like a bulletproof, extremely good paper, then you should aim for a journal with a high impact factor, and they will usually ask you for a reviewer, and you can figure out that one. So it all depends upon what kind of paper that you are presenting. Similarly, if you are presenting a case report, then you should aim for a impact factor which is a bit low, because case report is just a bit easy to publish. If you are presenting meta-analysis and systematic review, then you should focus more on a journal with a high impact factor. That's the only thing I want to add.
Excellent. Thank you, Dr. Nawat. Yeah, so Jane is very important tool that one should not. So it will help identifying the job, for example, curious, but you can try other ones with high impact factors. So New England of Medicine, for example, or JAMA, BMG. These are very high impact factor journals. So it depends on if you want to just publish something or you want to go ahead with high impact. Sometimes the cost might play a role as well. So. Dr. Nawat, thank you, Dr. Faida. Dr. Ahmed, you want to share your comments?
No, yeah, like really, thank you for you, Nadir, and the speakers. And really, this is a very nice word about the GAIN, which is like journal author name estimator. This is just to know when you are sending your abstract, and really it is a very nice for us to learn about this tools. But I have nothing else to add at this time. Thank you, Nadir.
You're welcome. And as far as conference that you want to, let's say, share your abstract or your poster, I think there are a couple of websites that can be useful. Sometimes some might have some support from like pharmaceutical, but I'm going to share with you some. So if you search conference finder, you can have Conference Monkey, conference to go to. So for next year, for example, there are different conferences, seminar, meeting, and you can find your area of like that match what you are interested in. sometimes you can go by the association, let's say cardiology association or geriatric association or nephrology association. Sometimes you can go by local conferences. So you can locate the conference in your area. So each state, they have their own chapter of the national, let's say the American Geriatric Society. They have Michigan State chapter or New York State chapter. Same with American Medical Director Association. They have Michigan State chapter. So each chapter or small conference of the state, they have their own local conference date as well. So you can locate, let's say you want here in the US, you can identify the date, the ending date, and if you want the specific area. So you can search for the conference. You can find just anyone, basically. So you can have a list of all the conferences, either displayed by the dates, like in June will be this, in August will be this, or you can identify by the location. I want something to be located near the where I live, so I want something I can drive to the conference. So you can identify or select according to the month, date, or by the topic or by the location. So this is another way of identifying conferences. The best way is to look at what we did in the past. So we participated in NAPREC, so they can accept our posters in the future, hopefully, because we know what they and we met their requirements, and we can look at their previous abstract. Also, the Society for General Internal Medicine here in the region in Michigan or midway here. Pain conference, we have the American Association for Neurology is one conference. So this is a list of what we participated in. Psychiatry Association, they have conferences. There are some virtual, so you can go to the virtual challenge and see if you can participate in some of these. AMDA is always there. So this is just a short list of what's available, but you can Google any conference finder website according to what your topic, see if they match your need or your area of interest. You can look at their website, see what's the deadline, what's the requirement, if they have templates, what the limitations, if there's word count limitation and so forth. So if you need help, we are here to help. So the seniors can help you. I'll be available, but I will be available to help. Thank you.
One thing I want to add, Nader.
Go ahead, Dr.
Yes, so especially about the abstract presentation, sometimes like you have a very nice abstract and also you have your data and your conclusion and you want to present your thoughts. The most important thing, because the abstract you are at the very beginning, so be open-minded and you have the data, but usually with a discussion with your colleagues at other institutions, you can come up with different ideas and even with a different interpretation of your data. For example, there is a paper about the in neurology, and they look also into relation of hysterectomy and bilateral salpingio-oophorectomy. So they are heading like at a specific thing, but in discussion, the author found that actually bilateral salpingio-oophorectomy or patients who have this surgery are prone to have other comorbidities, and including the other thoughts. His paper become like a landmark paper. I could share it with you at some point. So the point I want to make is always at the stage of the abstract, think about these data could have another signal, and you could know about it, or another colleague of yours, by just questioning your data, could draw your attention to that. So always we will be open-minded. We are not sticking to one thing, because your objective is this data will either establish or negate certain things, but you can come up with different new things. So this is a point I want to make. Thank you.
Thank you so much, Abdelrahman. Thanks. Any comments from the fellows? So I would like to just share one article, and before we go to the project updates. This is an article that was published 2 months ago. So virtual visit trends in nursing homes during the COVID pandemic. So this can be done easily, but we used it, actually my colleague, Dr. Raza Haq, and his co-authors, what they did, they looked at 3 nursing homes here in Michigan and looked at the patients who were visited using telemedicine. So basically, patient in the nursing homes will have some complaints. The nursing staff will be asking the doctor to see the patient. If the doctor is not available, then they can do the telemedicine visit. So what they did is they looked at all the telemedicine visits between December 2020 until February 2022. So during the early pandemic until last year. So what they did is they looked at the chart, and they did it, as I told you, using the IT, the team from the technology part. So here at MSU, we have the billing department. We send our billing code to them. They will collect the information and submit to the insurance. So this information will be saved in a database. So the first thing you want to do is you think about the question, the method. So they obtain the IRB approval. They reach out to the IT team and they ask them to review the chart. So they have 283 encounters where the patients were seen remotely, virtually by the physician. These are the number of patients. Some of them might be seen a couple of times. So the total number of visits, more than 500. So they used the ICD-10 to diagnose, to see the most used encounter diagnosis for the visit. So let's say the patient was complaining of chest pain. So we'll see the patient and we'll ask them question, we'll do the exam remotely. Maybe we can ask some X-ray or lab be done, and then the patient will be treated in the facility, or if we think it's MI or something, then we will send the patient to the hospital. So this will have a diagnosis or maybe list of diagnosis during the encounter. So this will be listed using ICD-10. And for those who don't know the ICD-10, it's basically for each diagnosis, they have a code that's internationally recognized code. For example, if it's essential hypertension, it's I-10, and so forth. So I'm gonna just answer this question of the phone, and I'll let Dr. Ahmed explain the. So the ICD-10 can be used to get the billing part, but we can keep it in the EMR so that we can talk about the same condition if we write hypertension or if we write HTN, something like that. Or sometimes they put the whole hypertension, primary or essential hypertension. So this is a way of using only letters and numbers to identify one condition. So all will be in agreement. And this is the explanation of that condition. So for this paper, they use the ICD-10 diagnostic code for each visit. And what they found, here's the results. So most of the patients were seen for non-COVID related during this time. And the conditions they were seen for hypertension, for diabetes or diabetes with complication, for UTI symptoms or infection, and patients with like they may have BPH and the patients with AFib. So these are the common what they found in their review of the chart for these patients during this period of time. So when I read this article, I can come up with my own experience. I can say, in my experience in this area, we saw more patients with complications of COVID during the pandemic, or we saw patients with this and that. So we can write a letter to the editor, either adding, supporting these findings, or contrasting or sharing a different findings from our experience. So this can be another way of publishing or adding to the literature. The third way is to look at this and how can we replicate this. So this was done during a certain period of time where it was early in the pandemic, during the pandemic, but none after the vaccination period. So maybe we can repeat the same concept. We can look at the charts and encounter virtual visits during the period from March 2022 to December 2023 and see if we can find any difference as far as the encounter the ICD-10. To do that, we can write a proposal for the IRB. Most likely it's going to be a faster one because there is no identification information we are collecting. When you get the IRB, we can go ahead talk to MSU database team and give them our proposal. They will collect the information. They will give us data. We're gonna look at the data, analyze what's the ICD-10 most common used during this encounter. And we can compare during early COVID pandemic, these are the common conditions that we saw in this setting, in this case, nursing homes, compared to the conditions seen later on after the patients in these nursing homes were given more than one vaccine dose. So we can say because of the vaccination, this is what we found, or maybe it's related, maybe it's not, something like that. So we can write a similar article using the same method. If you read the article and you are interested in the topic, you can just see what's the limitation here. So the limitation is this is done early in the pandemic between 2020 and 2022. What happened after 2022 to 2023, we can investigate this further. So if someone is interested, we can go ahead and start the project. So we will need a project leader and some team, and we can submit this article to the same journal because they are interested in the topic. They already published an article. This article will be similar or less as a continuation of what's published, and we can add to the literature. So this is how you can think about how you come up with some new ideas, new research. And if you want, you can use the same method used in the past. Any questions? Ahmed, you want to add some comment?
About the ICD?
Oh, go ahead with the ICD, yeah. Or in general.
In general, okay. Thank you. The international classification of diseases is really it is important because it helps us compare or comparability in the collection, classification, and processing and presentation of some data concerning our patients. So it is on all kind of hospital up to tertiary hospitals. It's helpful because as Nader, if you look at the Nader presentation, we could use this to classify and help us identify some patterns and if they are statistically significant. We use it for billing, but we could also use it for research. But also we have to be careful because the assign of the ICD-10 to different diseases or different diagnosis, it depends on the practicing physician. For example, even in hypertension, you can find many levels. And heart failure, patients who are stable and who are decompensated. Okay, and you see from another presentation, if I understand it right, like in COVID-19, there is different assignment to the level of the severity of the illnesses. So these kind of things, it has to be put in mind while dealing with the ICD diagnosis. For example, but if we come a couple of years back, we find ICD-10 or ICD-8 or even different. But and as we move forward, it is always people are revising the ICD codes, and we'll go from there. But it's really very important thing to talk about. Thank you.
Thank you, Dr. Ahmed. So as Dr. Ahmed mentioned, so the congestive heart failure, for example, there's diastolic, systolic, or combined. So if you want to be specific, you can specify that. And each one, they will have their own code and so forth. So it depends on the practitioner, as Dr. Ahmed mentioned. You can define it as just, I want this patient to be listed as congestive heart failure. I don't want to specify any type. Is it acute? Is it chronic? Is it diastolic, systolic? So this is the code for that. If I want to go ahead with some specification, then the code will be more detailed. So, and this is how you want, when you want to look at the chart from electronic point of view, you want to collect your data from the chart. It's faster way of looking at patients with, let's say in this case, congestive heart failure, chronic, diastolic. So I'm gonna just use this code. I'm gonna give it to the IT team. They will run a query in their database. They will look at all patients with this code and give me the list. Then in my list of these patients, I can look at their age. I can differentiate between older adults or younger. I can look at their male, female, gender. I can look at other conditions. Let's say we are talking about COVID, if they have COVID in the list or not. If I want to look at COVID, it has on ICD-10, for example, this one. So you can use it, and the team from the technology part, they will use a query using this ICD-10, collect all the information for you. It's going to be faster, and you can start your analysis after that. So this is just helping us to collect information from the chart easier and faster. Thank you. Any other comments from anyone before we go to the last part where we can talk about any project update, and you can go ahead. Let us know how you are doing, guys. Thank you. So if someone is interested in starting the project that we just were talking about, the virtual visit trend in nursing homes during the pandemic, we can change that into something different. It's a nursing home visit, virtual or telemedicine, and can be at the end of the pandemic, if we think the pandemic is done now. We can look at the information from the same nursing homes so that we can compare our data to the published data, and then the difference will be the time. So if anyone interested, we can go ahead and start a team and be the project leader for that team, whoever available, and we can work on getting the RFP approval, and then the data collection will be easier. Thank you. Any other updates as far as your projects, your mobile app, or any? So I'm going to ask Neda Tahrok, please, if you can, collect the information from those who are interested in writing the paper. So everyone can reach out to Neda and maybe Ali Bashir. Both of you will be collecting the team as far as who will be interested in this topic, and then we can take it to the next step. We can identify who wants to be the project leader, and we can divide the task and so forth. And Dr. Amal, do you have any updates as far as mobile applications?
So yes, I think we're almost done with the emergency educational application. We are now trying to figure out how we can upload it to App Store. It's a new experience, but we are trying to learn about it. And
So
soon
you
enough,
finished with the app? You finished?
yes, almost like 1 page left, but all pages are done.
I think Apple app, they have their a way of, I don't remember, it's like online sharing between users before you actually submit it. So you can test your app for users with iPhone, for example. So you can upload it as a functional app in not the store itself, but in an environment where it will be functional and you can test it. You can ask others to test it.
I'm not sure about that actually. I haven't started like the process.
Yeah.
But Google Play has the same concept of testing the app prior to publishing in the store.
Yeah, I think it might be a good way of doing it to test it and see if it's functionally well, or if you think it's okay to submit. I think the process, it might be tedious, but it's doable. So they have very specific,
I think it's going to be hard because they have many rules and like they want the app to be built in a specific way in order to be uploaded. But we are going to try and we are going to learn lots from this.
Yeah, there are a lot of videos that I saw that will explain, or at least there are some tools to help, like if you want to get the details of the icon, for example, they need a lot of sizes. So thank you. Good job.
You're welcome, Dr. Nader. Thank you so much.
Yeah. All right. Any other updates from the fellows? So before we finish, any final comments, Dr. Ahmed, to the group?
Hello?
Hello, go ahead.
Yes, thank you. Thank you, Nadir. Thank you for the nice meeting. Thank you with meeting with everybody. Really, I have enjoyed it and I'm looking forward for more to come. Please feel free to send messages or if you have any ideas or anything you want to discuss, we are here. It is always great to be with Nadir Jalal, my colleague. And Nadir, next time we want to play soccer together, okay? Thank you.
It's a great opportunity to have you, Dr. Ahmed, and thank you for showing up, and thanks for your wisdom, your expertise, your advice to the fellows. Thanks for sharing all this with us. Thank you.
Absolutely. We are learning together. Thank you.
Thank you so much. I'd like to thank all the attendees from today's and those who will watch the recording later. Thank you, everyone, and thank you for your interest and the good work that you're doing, and I wish you all the best. I hope to hear good news from the ones who did have some interviews. I know it's season. For those who did not get any, I encourage you to reach out to the programs most of the time there will be some cancellation last minute. So if you want, you can reach out to see if there are some, and if you are available to do either virtual interview or on spot in-person interview. I wish you all the best, and we'll see you next week, inshallah. Assalamu alaikum. Thank you, everyone.
وعليكم السلام. مع السلامة.
وعليكم السلام. Thank you so much.
Thank you so much, Dr. Nadir.
You're welcome. So,
Thank you so much, Dr. Nadia. Happy New Year.
you too. Thank you very much.
Thank you, Dr. Nadir. Jazakallah khairan.
Jazakallah khair. Thank you very much.
Thank you so much, Dr. Nader.
Thank you so much. Allah.
Allah.